generally, as we all know, as surgeons and clinicians, most joints are treated with an arthrodesis by removing the cartilage or the surrounding tissues and obtaining a bony union between them. The sacroiliac joint has been treated differently, which is unique and needs to be understood at a higher level. And typically the technologies around this are more focused on placing transfixation devices, typically from the iliac side across the sacroiliac joint, whether intra-articular or extra-articular, and then connecting that to the sacrum, obtaining a fixation. With that, this debate, I guess maybe a discussion is better to call it, it has reached the forefront, and we're very grateful to have Dr. Cross and Dr. Dengler give different perspectives on this. So what I'd like to do, and I think this is what we've already agreed upon, we were going to have Julius Dengler. Dr. Dengler, thank you very much for being here. And you were one of the lead authors on a very important article recently, within the past couple of years, published in a major orthopedic journal, the Journal of Bone and Joint Surgery. And we would like you to summarize your findings, and then we will have Dr. Cross discuss other ways to manage the sacroiliac joint in a more traditional arthrodesis fashion. With that, Dr. Dengler, appreciate it.
Jeff, thank you very much for the introduction, and thank you, Woody, for being part of this event, and thanks for everyone at SIMEG. Can you see the slides? Okay, great. So I'll take on the first half presentations here, followed by Woody, his perspective. This debate in general has the title, "What is the best method for long-term outcomes?" Let me just try to shift over the Zoom windows a bit so that I can see my screen. That's fine. So I suggest a bit of an alternative title as well: SI joint fusion versus fixation, a debate on an unlevel playing field. My disclosures: I was an investigator in the AMIA trial, which was sponsored by Saarow, but I'm not any more involved with it. I'm not involved more with the company than that, being the investigator. I'm located in Berlin, or on the outskirts of Berlin, a beautiful lake. We have a lot of lakes around Berlin. And I just told Woody that I have a commute of almost an hour every day to work, which is unusual over here in Germany, because I live in Berlin. So in researching the issue, I went to the SIMEG webpage and to see what the general vibe is there as far as implants go. And SIMEG is not recommending or preferring any technique. Efficacy needs to be approved by appropriate clinical studies. And the website actually helps you. They say, click here to get a better overview. So I did that, and it transfers you to the Spine Marketing Group site. I didn't do any more research on that, but they actually give you the 12 top competitors in the SI joint market, which is the list here. But they also, in the lower part of the section, they also list all the others as well. So they come up with 26 implant devices, and therefore I think that's pretty much the reality at the moment, probably plus minus a couple. So if we look at the numbers of publications on this issue, of course, as in most other subjects as well, there was kind of a publication bubble, or there still is a bubble going on. There's a lot of increases in publications themselves, but also in citations. So this is really, let's say, a well-published situation at the moment for a small niche area like the SI joint. So I'd like to talk first about the SI joint fusion devices without published evidence. According to Himstead and colleagues, who did a scientific systematic review on this, which is a lot actually. So a lot of new players or smaller players in the market actually have not published so far. And there are a group of fusion devices with evidence, yes, but mainly observational, but still they have numbers on the board. So for example, and this is not going to be complete, it would take too long, but I'd like to mention, for example, symmetry. This is Woody's paper from 2018, which is a retrospective observational multi-center series, 19 cases followed up for 2 years. SILOC as well has a publication, Rappaport in 2017, retrospective observational motor center 32 cases, followed up for 1 year. And Diana Volker-Fuchs paper from 2018, which is one of the few prospective endeavors in this area, prospective observational multicenter, and they have almost 200 cases basically, so quite large, and they also followed up for 2 years. However, as I said, there were no controlled groups, and this was non-randomized, but observational. Now, if we go beyond this, the air gets quite thin. The SI joint fusion devices with randomized control evidence basically just leave us with iFuse, SI bone. They had these 2 trials, of which, as I said, I was involved in IMEA. INSIGHT took place in the US, IMEA in Europe, pretty much the same setup. INSIGHT had 150 patients, IMEA 100 patients. They followed them up for 2 years, and they were randomized, conservative versus interventional treatment. In addition to that, iFuse also ran a separate observational registry, SIFI, exclusively in the States, but also following up over 2 years. And we'll talk about long-term evidence as well. We have to mention LOIS, which is actually a fusion between the INSIGHT and SIFI studies, and actually followed up 103 cases over 5 years. So that's pretty much the situation scientifically. Now, if we look at the idea of an unlevel playing field, this is the reason. There's a lot of publications, as you're all aware of, basically on this one type of implant, due to a lot of reasons, of course, mainly the industry driving this, but also they were pretty much the first. And so they gained some traction pretty early on. Now, let's look at outcomes. What about the outcomes of the non-RCT studies? Again, the same example. Symmetry, obviously also a nice reduction in VAS pain over 2 years. SILOC, pretty much the same picture, both in VAS and in ODI, significant decreases over time. Here only followed up over 1 year, but still there is an effect. And Diana, also a solid effect over a 2-year follow-up, both for ODI and VAS. Now, this is quite similar to the RCT results. We see here the VAS for the iFuse studies, IMEA, INSIGHT, and SIFI. It's not so important to know which line is which, but what's important is the lines up here. This is the conservative groups in SIFI and in INSIGHT and IMEA. So there was a 6-month follow-up for conservative group. A lot of them were able to cross over to the surgical group. So we unfortunately lost a lot of cases here after 6 months. But I think this control was worth it, because it really showed how frustrating conservative treatment is on the SI joint. And I'm sure you're all aware of the fact that we really don't have any good data on conservative management of SI joint. Now, same numbers or similar numbers for ODI. So what about long-term? You look at the non-RCTs. I said we don't have any evidence on long-term beyond 2 years, at least as I'm aware of. Now, the RCTs, they actually published the 60-month 5-year data from the LOIS, as I've mentioned before, and they were able to show consistent improvement over this time period, which I guess can be termed long-term. So what about this unlevel playing field situation? Now, looking at a summary of what I just said, we have as the most lightweights the devices without published evidence, which are being outweighed by those with observational evidence. So of course they are more heavyweight, but this whole situation actually also plays out on a whole different field, which is this. It's being outweighed by the immense amount of iFuse publications. So that's the situation on the scientific front. Now, back to our initial question. So what is the best method for long-term outcomes? And if you look at the conclusion of this systematic review by Himstead and colleagues, they concluded it is the responsibility of the physician to evaluate the current literature and utilize the device that is most validated to produce high-quality outcomes. So does that help? I don't know. We've seen the situation, and this is a quite general statement, I would say. So I'd like to add some fuel to the discussion here a little bit. How should we discuss this on this unlevel field? Does iFuse, for example, have a weakness that may level this field a bit? And I think this is where most of the critics of the iFuse dominance on the market come into play, because of course we're aware, and Woody is going to talk about this with more knowledge about the situation that iFuse actually does not use active bone grafting, but others do, and the true value, of course, from other parts of surgery that we know of. And we all value true arthrodesis a lot, I'm sure. But again, if you look at the implants, you have to agree that the Siloc, the Symmetry, and the Diana, at some point, they do add some type of bone graft to the implant, either around it or into it. So they make an effort to fuse actively, versus iFuse does not do that. They rely on the triangular shape, on this porous surface, which is meant to grow bone over time, which has been auto-grafted, so to speak, in the process of implantation. And it's actually quite interesting to look at a push-out specimen of one of those implants. You see a lot of bone ingrowth, on-growth, and through growth after a while, and the data to this are quite clear. A lot of, or at least some people that are critical of the iFuse implant expect this situation to be quite frequent. You see the lucency on the sacral side of the implant, but to be honest, this is a rare phenomenon. Anyone who implants a lot of these iFuse devices really sees this quite rarely. And we did the scientific workup on all the RCTs and the observational trials. Inside, we had the situation in 2%, and IMEA in 4%, SciFi 3%. So I'm sure the other implants have the same challenge, and maybe even more of it. I'm not sure, but this is something that is very rare in iFuse. So, and even another point is that we do see new bone formation, so-called bridging bone, in the prospective series as well. Of course, at 1 year, it's quite low at 45%. At 2 years, it goes up to 71%. At 5 years, we have 88%. Now, of course, you can argue, what does bridging bone mean? There's no real unique or clear definition. Bridging bone can mean that there's some type of bone formation along an implant. The question is just, do the bones have to kiss? Does it really have to build a complete bridge? At least there's some activity going on. And what we found is that in none of the prospective studies was there a correlation between absence of bridging bone and negative clinical outcomes. So it doesn't seem to be that important, at least in this type of technique, to have bridging bone. Now, again, what's the best method? To add some more fuel to the discussion, does a patient really care about anything other than clinical outcomes? Does a patient, or do we really care about true arthrodesis versus fixation without active bone grafting? And how easy is it to learn a specific SI joint fusion technique? These are all points I'd like to add to discussion. So thank you very much for the chance of letting me talk here. And then I guess we'll hear Woody's perspective next.
Thank you, Julius.